Good afternoon, guys, and welcome to the second presentation for our APS503. And this is the generally poisoned patients focusing on illicit drug use. I am Michael Wood. So, first of all, what are illicit substances? Now, poisoning and the ingestion of illicit substances is a worldwide problem that consumes a substantial amount of healthcare resources. The ability of drugs across the world is very, very high. It's not difficult at all for people to acquire illicit substances, and illicit substances are commonly ingested, though you can also inhale drugs, insufflation, cutaneous and mucous membrane exposure, and of course injection. And despite the high prevalence of drugs, serious clinical effects occur in less than 5% of patients, and in-hospital mortality rates are less than 1%. Now, illicit drug use is often linked to a range of other factors such as mental health problems, alcohol misuse, and homelessness. They normally go hand in hand. It's unfortunately one of those what came first, the chicken or the egg, when it comes to trying to figure out how these patients have ended up in these situations. It's reported that more than a third of adults have taken an illicit substance at some point in their lifetime, and those aged between 16 to 24 years of age are more likely to be frequent drug users. Now, the most common illicit substances that are abused are marijuana, cocaine, heroin, amphetamine or methamphetamine, GHB, which is gamma hydroxybutyrate, and MDMA or ecstasy. And MDMA and ecstasy is going to be the drug that we focus on for the rest of this presentation. We have a quick video to watch that I will play for you now. So I found that quite interesting, particularly of note that drug users are getting older. Now, that may not be true for the use of MDMA, but may be more likely for marijuana. And a few of those statistics are quite interesting if you want to pause the video at some point and have a closer read through those if it went through a little bit too quickly for you. So now we'll have a closer look at ecstasy and MDMA. So 3,4-methylene dioxymethamphetamine. Bit of a mouthful, we'll stick with MDMA. It's also known as ecstasy, though ecstasy is actually a same compound but a different drug, if that makes sense. So MDMA is used in the process of making ecstasy, but the two terms have been interchangeable historically. So MDMA was developed by a German chemist in 1912 as a possible appetite suppressant, and it was kind of left on the shelf, widely unused or abused until the 1970s, when drug culture really started to kick off in America, and it was eventually discovered to have recreational psychedelic properties. it became profoundly popular with participants in raves from the mid-1980s, as it was found to enhance energy, endurance, sociability, and sexual arousal, and is believed to be a safe drug by those that used it. Very limited side effects that they could find at that stage. It led to widespread use. It has been shown recently, however, particularly in the media in the past couple of years, that there are serious acute and chronic toxic effects that MDMA can have, notably in the past 3 or 4 years with music festivals such as DEF CON, where there's been multiple fatalities. Now, the most salient acute effects of MDMA are mood enhancement, increased energy, empathy, and euphoria, much like I just mentioned. But there are also a number of serious side effects that includes the disruption of thermoregulation, severe tachycardia, severe hypertension. It can lead to seizures and intracranial hemorrhage as a result of the hypertension as well. And now the pro-social effects of enhanced sociability and feelings of closeness with others have continually motivated the recreational use of the drug. So people are taking this drug because it makes them feel happier, it makes them want to talk to people, wants them to be more personable, and it gives them the energy to do this all day. So if you go into a music festival and they take some at 11 o'clock in the morning, they're still going to have energy at 8, 9 o'clock that night, despite all of the effort and all of the exertion that they've been putting in. So let's have a quick look at how MDMA works. So it's a potent yet indirect monoaminergic agonist, and it's believed that it increases the release and inhibits the reuptake of serotonin. So it's similar in this process to cocaine. Cocaine does a similar thing where it blocks the reuptake of noradrenaline in the synaptic cleft. And so it's and MDMA also does this with serotonin, but to a lesser extent, dopamine and noradrenaline as well. Now, why is that important? It's because, well, serotonin is involved in the regulation of mood, anxiety, and aggression, whilst dopamine is a primary neurotransmitter of the reward pathway. So you're going to have those feelings of euphoria, you're going to feel good, you're going to feel like you've achieved something, but you're also going to have a big uptake in the amount of energy that you have as well. This also leads into where we develop problems with MDMA use, as the toxicities associated with MDMA are linked to increased serotonin or 5-HT levels, and this can cause a serotonin syndrome, a potentially life-threatening adverse reaction from illicit drug ingestion. Now, serotonin syndrome's main feature is a neuromuscular hyperexcitability, which normally mild, though can become life-threatening. So we can have small muscle fasciculations as your neuromuscular junctions depolarize and cause small muscle twitches. Now, other issues that arise from MDMA usage is you can have hepatic toxicity. So this is through delayed metabolism of both the drug and its metabolites. So this causes significant biochemical changes as the drug passes through the liver, causes damage to the liver as it's metabolized in the first place, and then it creates toxic metabolites that then further cause issues. Cardiovascular toxicity, with the release of noradrenaline and the inhibition of reuptake, it causes significant hypertension. This significantly raises the risk of stroke, as well as persistent increased cardiac workload has a potential for heart failure through cardiac remodeling if this is a drug that's being used daily for a very, very long time and leading to cardiomyopathies. It can cause cerebral toxicity. So the vigorous physical activity and energy expenditure that's associated with the use of MDMA causes the patient to sweat profusely, and this causes hyponatremia. Now, this coupled with excessive water intake causes the passage of water from blood into tissues, into the cerebral tissues, and seizures can occur. One of the most crucial elements of MDMA ingestion, as is going to be looked into quite closely as we go on further through this presentation, is this hyperpyrexic pattern of toxicity. So intense physical activity results in hypothermia. This hypothermia causes rhabdomyolysis. Now, rhabdomyolysis is the breakdown of muscle tissue. So as the breakdown of muscle tissue occurs, intracellular potassium, which is vastly greater at vastly greater levels than extracellular potassium, is released into circulation and into the extracellular space, and this can cause hyperkalemia, a significant risk of mortality from this. As the breakdown of the muscle occurs, also there is a release of other contents that can worsen liver function, and the release of myoglobin can severely damage the kidneys, and you can result with myoglobinuria as well. So it's a bit contentious at this stage, as these 2 points that are up on the board here at the moment contradict one another. So this case that I found, or this study rather, has stated also that persistent use of MDMA has been shown to develop tolerance for the drug, as serotonin requires greater dosages to achieve the desired results. So, as with most drugs of addiction, you need more and more of it as the body becomes desensitized to it to achieve the results that you want. However, current data has provided modest evidence for a chronic tolerance to the effects of MDMA, and provided little evidence that the initial experiences when first using the drug are dramatically greater than subsequent experiences. Now, whilst it's been proven that physically the body requires more of the drug to achieve the same levels of serotonin release and reuptake inhibition, the actual perception or the feelings of happiness and energy doesn't actually differ despite the buildup of a tolerance. So let's move on to the clinical features of MDMA intoxication. So it's been found that MDMA produces a significantly increased systolic blood pressure to greater than 160 milligrams of mercury, millimeters of mercury rather, in 1 in 3 patients. It causes an increased heart rate to over 100 beats per minute in 1 in 3 patients. And it can cause an increase in body temperature to greater than 38 degrees Celsius in 1 in 5 patients. These figures significantly increase in relation to greater doses. So the more drug that you take, the more likely you are to produce these symptoms. And if you're a male, and males are more likely to have these symptoms produced also. And this was done in a test by Vazelli and Lichty in 2017. And reading through the case report is quite interesting in that despite identical drug doses, men still had higher presentations of increased blood pressure, increased heart rate, and increased body temperature. It's not so much a men generally take more. This was a study that was done in controlled lab conditions. So in looking at serotonin syndrome, for the massive amount of serotonin in your body, the classic triad of cognitive, autonomic, and neuromuscular effects is the classic triad that we work off. So in a mild serotonin syndrome, you might have mild agitation, a mild fever of less than 40 degrees. You'll have that tremor, myoclonus, hyperreflexia, as I was saying, for those like muscular fasciculations. You have mydriasis, and elevated blood pressure and heart rate. Most patients that take MDMA will have these symptoms when taking it as an indicator of the increased serotonin within the body. Moderate features of serotonin syndrome, they'll have marked agitation, they'll have a hypothermia that is now above 40 degrees, they'll still have the myoclonus, they'll still have the hyperreflexia. Now they'll start to produce ocular clonus, and there'll be increased bowel sounds. And when we get to severe serotonin syndrome, hypothermia of greater than 41 degrees, which is related to significant mortality rates. Patients will become delirious, they'll have marked muscle rigidity, they'll be having really quick swings in both blood pressure and heart rate, as there's vasomotor loss of control, as intracellular contents is released, intracellular contents are released into the body, affecting the cardiovascular system, causing changes in blood pressure and your heart rate. So signs and symptoms that patients may present with in MDMA toxicity. So you'll have headache, agitation, nausea, palpitations, tremors, sinus tachycardia. They'll have a quicker heart rate. The fasciculations, as we mentioned just before, hyperventilation, as the body becomes hyperthermic, becomes slightly acidotic, and the patient tries to pick up the respirate to breathe off as much CO2 as possible to try and do a respiratory buffer of the acidosis. They present with nystagmus, hypertension, chest pain, hallucinations, and confusion, and that's all just in moderate MDMA toxicity. When we get to the severe toxicity, as we've progressed through hypothermia to hyperkalemia and into multi-organ failure, we've got coma, seizures, bradycardia, hypotension, and then worsening hypothermia. So this hypothermia or hyperpyrexia, rhabdomyolysis, and multi-organ failure post-ingestion of MDMA has been well described in the literature and seems to boil down to the excessive exertion that patients that have taken MDMA with the massive increase in energy and exerting themselves and not replacing the fluids that is exerted through sweating in appropriate fluid intake. And I mentioned this before, if the patient's condition has progressed to having core body temperatures of greater than 40 degrees, impaired consciousness, disseminated intravascular coagulation, hyperkalemia, and multi-organ failure rapidly follow. And these all have very, very high mortality rates in isolation. When put together in the one patient, these patients are very, very sick. So what are we looking for when we're examining and assessing these patients? So hypothermia is probably the most widely known acute adverse event that can follow ingestion of MDMA. It's important to note, however, that, as I said before, in lab testing, no single pharmaceutical agent has been effective in reversing this issue. And ultimately, careful body cooling remains the principal clinical approach. We need to cool the patient down as quickly as possible to avoid the progression of the condition to rhabdomyolysis and hyperkalemia. So performing accurate and frequent measurements of a patient's temperature will be a strong indicator into the severity of the current condition. And it may also shine a light on the progression of possible rhabdomyolysis and in turn hyperkalemia. So how are we going to look for, assess for, and manage hyperkalemia? Well, what's going to give it away for us best is ECG monitoring. So it's going to allow for the early identification of any hyperkalemic changes. So what are we looking for? Initially, we're going to have massively increased peaked T waves. So this is as the muscle has broken down, the potassium is released into the circulation, and potassium raises the resting membrane potential of the cardiac myocytes. Funny thing of this, though, is that when there is more potassium externally to a cell, then potassium wants to leave cells even quicker. So increased potassium will cause a rapid repolarization as potassium attempts to leave the cell during phase 4 of the cardiac action potential. And this causes the peak T waves, as it's a rapid depolarization and then a rapid repolarization, peaked T waves. We'll then be looking for flattening P waves and a lengthening PR interval. And then eventually we're going to have a widening QRS complex. As that resting membrane potential is raised, then there are less fast-acting sodium channels that can depolarize the ventricles. And so as there's less of these available, it's going to be a slower depolarization through the QRS. And that's why we have the lengthening and widening of the QRS complex. So other than ECG monitoring, what kind of things do we have to look for? What kind of the questions that we have to ask these patients? So in all, patients that present with an acute drug intoxication, they're usually not very forthcoming with information regarding what they have ingested. Some of them will be, some of them won't be. It all depends on the rapport that you can build up with that patient. Be sure to ask, however, specifically, what drug have you taken? How many of the pills or the caps, or how many grams do you think it was? How many mils? If it's whatever measure they use, just ask how much and how many they've had. have they done polypharmacy? So have they taken some MDMA, but also they've been drinking alcohol all day? Have they taken some MDMA, but also ingested some cocaine as well? As these will obviously all produce similar and at times different symptoms that you need to be quite aware of. When did they take the drug? How long ago? Did they take it 2 minutes before walking in, coming up to you for assessment, or did they take it 2 hours ago so that the drug has had time to affect the body quite significantly for a while? Are they a regular user? So have they become desensitized to the drug? And you need to make sure that you're consistently asking them, who they are, where they are, what they're doing. You want to do this mainly for your own monitoring of their GCS. Are they having any acute neurological changes, which is resulting in a deterioration? You also want to know if they have any underlying medical pathologies or conditions. Do they have a pre-existing cardiomyopathy or a pre-existing cardiac condition? Your simple ones, your asthmas, anything that can affect what you're going to affect the disease progression that may make it more difficult for you later down the track when you're attempting to manage them. So studies have found that when you are trying to manage MDMA ingestion, so not when you're trying to manage MDMA ingestion, but studies have found that not only does MDMA have physical effects that you need to manage, but also alters emotional perception and response to emotional stimuli. So as we were saying before, you really have to make sure you get a good rapport with these patients to make sure they trust you and you can get them on side and you can give them the best quality care that they need. The key points to the physical management of MDMA ingestion: early recognition of MDMA toxicity. So it's so important, like we said, what have you taken? When have you taken it? How much have you taken? Aggressive cooling. We really want to maintain normothermia, get that patient's temperature down and avoid rhabdomyolysis and hyperkalemia. And we also want to make sure that we're looking at rapid transport for these patients. These patients need a multidisciplinary approach, including ICU, anaesthetists, renal specialties. This is why we need to look at a team that has the ability to perform dialysis. And recently, there's been a large number of cases that have discussed the use of ECMO, so extracorporeal membrane oxygenation, for acute MDMA ingestion toxicity. So, as with any and all of our patients, once we build up a report, the management of a patient suffering from an acute drug intoxication should begin with a thorough and sound primary survey. We're assessing for any compromise of the patient's airway, breathing, and circulation, and any insult identified during this assessment should be treated immediately. And you can't move forward onto breathing if the patient doesn't have an airway. You can't move forward onto circulation if the patient isn't breathing. So simple bread and butter, day-to-day paramedic stuff. In terms of an actual treatment regimen, what are we going to do? So if the patient comes in to you, or you get to the patient and they are alert, if they're alert and they've not progressed down the stage of altered LOC, then that's great. Let's try and treat them symptomatically at current, make them comfortable. If they've come to you and they're aggressive, difficult to manage, difficult to control, then administering midazolam is going to have two really good effects. The first one is going to make your patient manageable. You're going to be able to do what you need to do for this patient. The second one is, if you're giving this patient midazolam, they're going to be they're going to settle down. They're not going to be exerting themselves. They're not going to worsen that hypothermia that already exists potentially. Now, if you get a patient that already has progressed to an altered LOC, then you want to place them lateral if they don't have an airway adjunct in. If you do have an advanced airway, say an iGel or a ETT, then you can have them supine. You've got a protected airway. You want to make sure that the patient is cannulated, preferably bilaterally, because if it does progress through towards hyperkalemia and a significant amount of management this patient needs, then having two lines is going to be much, much easier for you. You want to titrate your oxygen administration to 94%. You want to make sure that they're not hypovolemic. If they've not been drinking any water, like we were saying before, they've been sweating quite profusely as well. We want to fluid resuscitate this patient, 20 mils a kilo of compound sodium lactate. We want to aggressively cool them. Ice packs in the groin and armpits, remove the hot clothes, get a bit of fans happening for convection. We want to try and aim for normothermia as best as possible. If, as we were saying before, there is some cerebral swelling or there is some sort of cerebral insult, then we might have seizures. Seizures can be quite common in these patients. As usual, normal management for a seizure, give some midazolam, airway management. If the patient has progressed through to hyperkalemia, we want to be looking at our ECG. And working for New South Wales Ambulance, we have access to calcium gluconate and sodium bicarbonate, and those are our two drugs of choice to manage hyperkalemia. We could also use Ventolin, large amounts of nebulized Ventolin, beta-2 agonist. It's going to drive that potassium back into the cells as well. And during all this management, we want to make sure that we're regularly and closely monitoring our vital signs and ECG trends. So let's say that our patient has progressed to the end of rhabdomyolysis, and we've noted that they're hyperkalemic. So as for New South Wales Ambulance, hyperkalemia, these are our indications for treatment with sodium and cal-gluc. So actual or suspected hyperkalemia So we've got suspected hyperkalemia because we know they're taking MDMA, the hyperthermic, and this is what we're looking at. So we have ECG changes. Do we have our tall peaked T waves? Are our P waves flattening and disappearing? Is the QRS widening? As that QRS widens, the T waves have peaked, the P waves have disappeared. It's the presence of a sine wave pattern, or sometimes also known as a Z-fold pattern. Now, in MDMA toxicity, due to the fact that the potassium is released so quickly, you will usually be able to see ECG signs of hyperkalemia quite easily. However, got to remember that in other patients, so patients that may be taking slow K that have overdosed slowly over time, or crush injuries that may not have massive increases of potassium immediately, progression of ECG changes may not be observed. If it slowly picks up over time, then the ECG might actually change. So the drugs that we're going to use, so we've mentioned before, oxygen titrated to 94%. We want to make sure that we've got the ability for oxygen to be delivered into the cells so that aerobic metabolism can occur, and this is going to mitigate acidosis. We're going to make sure that we're not using anaerobic metabolism, we're not producing lactic acid, we're not propagating any issues further down the track for the patient. We're going to give the compound sodium lactate, 20 mils a kilo bolus whilst signs of shock are present. So Hartmann's, it's a crystallized solution. It's going to increase that circulating volume, fix our BP problems, and also might have a cooling effect. If it's a hot day and the bags of fluids have been in a nice cold ambulance, it could cool that core body temperature down as well, which would be fantastic. Midazolam for either seizure management or patient management, 2.5 milligrams IV, 5 milligrams IM. It enhances the affinity of GABA, which is an inhibitory neurotransmitter. It makes GABA want to attach to the GABA receptor on the postsynaptic cleft, which is going to drive chloride into the cells, which is it causes a negative change within the cell and stops any action potentials. Here's our hyperkalemia management now. So the calcium gluconate, 1 gram in 10 mils up to the age of 16, or if it's in a pediatric, depending on how old the patient, we'll be looking at 20 milligrams per kilo. So it's a slow IV push administration over 2 minutes. We really want to make sure that we are in the vein when we're giving calcium gluconate. It's hyperosmolar. We don't want to tissue this vein. We don't want to tissue this drug. It'll cause quite nasty necrosis if it does extravase. Now, how does calcium work? So I was saying before that potassium raises the threshold membrane potential in the cardiac action potential cycle. The administration of calcium is going to decrease the excitability of cardiomyocytes by increasing the charge of the membrane threshold potential. So what we're going to do is we're going to restore the difference between threshold potential and the resting membrane potential. Sodium bicarbonate. What are we doing here? So it's 1 millimole per kilo IV. One thing we do want to make sure is that we've given a really good IV flush between the administration of these two drugs, because they can precipitate if they go through the line at the same time. So I digress. So sodium, what we're going to do with this? So enters into the body and it dissociates into sodium and bicarbonate. The sodium works at a cellular level by working in a sodium hydrogen exchanger on the edge of the cell. So sodium goes into the cell, hydrogen comes out of the cell, and that lessens acidosis within the cell. The sodium that's then entered the cell is then going to work within the ATP pump, and it's going to exit the cell once again, and this pulls potassium back into the cell, trying to lower the serum potassium extracellularly. Going back to step one, when sodium exchanged with the hydrogen, the bicarbonate ion that we've now put into the system as well is going to pick that hydrogen up. Once again, it's then going to reduce systemic acidosis, and that's going to enter into the blood buffer cycle through the use of carbonic anhydrase and increase the breath rate, breathe out the CO2, and hopefully mitigate anything that's happening there. So we've treated our patient, we've figured out what we need to do and what we've done. So what are we going to do next? Now, certain life-threatening conditions require immediate, meaningful treatment of reversible causes whilst on scene, with all of the treatment en route and rapid transport to hospital for further assessment and treatment. If you have a patient that is appearing hyperkalemic, you need to treat that hyperkalemia in the instance, make sure that you're protecting them from getting any worse, and then get them somewhere where they can be fixed properly. So the geographical location considerations are: time to definitive cure. How far away are you from the actual hospital? Time for extra assistance to get to you. If you're a long way, do you need someone to come and help you on the way? Do you need to come to where you are now, or do you need to meet them on the way? The load and go or stay and play dichotomy. Who says you can't do both? You need to be able to treat this patient quickly, but also be getting ready to leave. Going back to what we were saying just before about making a decision of which hospital to go to, because they need that multidisciplinary approach. So the ability and capability of receiving hospitals, some smaller rural hospitals may be worth bypassing if the patient's presentation requires it. And you've got to make sure that you're going to pre-warn any hospital that you do go to with a heads up, give them a back call. Now, deaths associated with MDMA are rare, especially considering the widespread usage, as we mentioned at the start of this presentation. Drugs are rampant, but MDMA deaths are still rare. Most of the lethal events have involved hypothermia and its sequelae. So, as you know, it's the cause of death and then the subsequent effects of, once again, rhabdomyolysis, hyperkalemia. So, as hypothermia is difficult to control in the pre-hospital arena, all we can do is remove clothes, ice packs in the groin and the armpits, and try and cool them down that way. Early transport decisions should be made to appropriate hospitals that have the following capabilities. So you need a hospital with an ICU. You need a hospital that has renal dialysis. And as we were mentioning before, ECMO has become a possibility for these patients. So if you can get to a hospital that has the capability to perform ECMO, then absolutely you should look at doing that one as well. Now, the role of senior clinical practitioners in the pre-hospital arena, it's not purely clinical. So clinical leaders need to have a sound perception in both scene and crew resource management, as well as patient management. Diagnostically unwell patients require urgent, accurate, and efficient management interventions, and teamwork is critical for both patient and provider safety in high-stake environments. Let's take the example once again of a music festival. Large music festivals are overwhelming situations. And when there are drugs involved, individuals are less likely to be receptive to direction. You need to be sure to be firm, clear, and concise, not only to your team, but to the patient and to other stakeholders from other agencies. So you're going to have police on scene. You're going to have medical event crews on scene. There'll be other first aiders. You may have fire rescue. There's going to be lots and lots of people that may either need direction or will look to you for direction, or that you may need assistance from. So you've got to make sure that you identify yourself as a clinical or operational lead, and make sure people know that you're in control and that this is the way that you're going to want to do things, but always being receptive to any feedback that someone in the team will have for you. You've got to utilize the crew and resources around you. Use the police to control the crowd if it's a dangerous situation you find yourself in, and you've got to make sure that they manage the friends and family as well. You can also use the fire or event medical crews to assist with the manual handling of patients, getting patients from A to B. You may even need to utilize the doctor that might be in an event medical crew in interventions for this patient that might be outside of your scope of practice. The key CRM principles in any situations, particularly in situations like the music festival example, you got to have good crew coordination, strong communication, and good communication links. You got to make sure that any errors that occur, you're accountable for. You need to make sure that, yes, we've made an error. Okay, let's address it. Let's figure out what we need to do right, and let's move on from it. You need to be able to identify the strengths and weaknesses in your crew. If you have someone that's the best airway manager that you have in your team, put them on the airway. If you have someone who's not great at cannulating and you really need that cannula, perhaps do that cannula yourself if you're a stronger cannula. Just little considerations that you might need to make. You want to make sure that you outline your clear expectations. This is all about communicating with the team, saying, this is the plan, this is what I expect us to do, and this is how we need to do it. And then after, you always have to have the ability to self-critique the performance of yourself and your crew, and they need to be able to bring that back to you as well. So some key takeaways in managing a patient with acute MDMA ingestion: you've got early identification of the type of drug ingested, the route it was ingested, and how much. What was the drug? When did you take it? How much did you take? That's something you need to know quickly, because that then guides the rest of your management. In MDMA ingestion, you have to be acutely aware of the risk of hyperthermia and subsequent hyperkalemia. And this is going to be monitored by closely looking at vital signs and ECG monitoring. And this is going to be critical to identifying the deteriorating patient and at what point you have to intervene pharmacologically. You want to treat symptomatically at all times and aggressively. These patients can deteriorate very, very quickly, and you need to make sure that you're on top of their management. Good airway, good primary skills, airway, breathing, circulation, and appropriate symptomatic management and aggressive cooling. You then want to transport them early to an appropriate facility for their ongoing care. References up here on the slide. Thanks so much for listening to my talk on illicit drug use and MDMA ingestion. I look forward to doing the third video and getting some feedback. Thanks very much.